Verma. Thank you to the chairpersons and the speakers of the session. The debate follows. Clash of the Titans, Dr. Madhu Murali and Dr. Aswin Thangavelu. Dr. Madhu Murali, Additional Professor, Department of Surgical Oncology, RCC Trivandrum, and Dr. Aswin Thangavelu, Senior Laparoscopic and Colorectal Surgeon, Ashwin Hospital, Coimbatore. May I invite the chairpersons for this session, Dr. P. Rajan, Emeritus Professor of Surgery, Astor MIMS, Calicut, Dr. Bharat, Senior Consultant Surgical Oncology, KIMS, Trivandrum. 10 minutes each to the presenters and then 2 minutes rebuttal. May I hand over the proceedings now to our esteemed panel, Dr. Rajan and Dr. Bharat, please. We'll fix that, sir. Dr. Aswin Thangavelu first.
Good afternoon, esteemed chairpersons and my dear friends. So I've been given an interesting topic to talk on YouTube. I think once the presentation comes, I'll just start. So first we have to understand why we need a presentation like this. So in India, the GDP allocation for healthcare is very poor, and we know that various centers have different funding, right? Central government institutes have better funding, local states only in premium Tier 1 cities have good funding, whereas the rest of them, they don't have enough support. So what it invariably does is, we as surgeons are becoming more and more dependent on technology. For example, you know that robotic surgery is a very new technology which is evolving and coming into our practice. So it's all very expensive. So if you don't have good funding, you can't have access to these equipments. So when you don't have access, when you undergo a surgical training in a premier institute like an AIMS, you get exposure to all specialties. Whereas if a resident is getting the same training in a Tier 3 or a small village kind of a base medical college setup, he doesn't have access to all those facilities at all. How is it fair? Both of them get the same MS degree at the end of their residency, but the exposure levels and what they can get access to are totally different. So that is not correct. So how can we bridge these gaps? And as surgeons, we know when you take teachers, majority of us are good teachers. But when you look at excellent teachers, there are only a handful few of them. So here, I've just put a small example to emphasize the point. So basically, when you take a retrorectus repair, you have one right retrorectus compartment and a left retrorectus compartment, and both of them are separate. So here I have to teach a very complex procedure called a crossover to combine both these compartments into one single compartment. So how can we do it? So here I enter into the left retrorectus space, then we'll put my working ports. Under vision, I will divide the posterior rectus sheath on the left side. Then we will go preperitoneal and dissect the falciform down. And then we will divide the posterior rectus sheath on the right side. And now you can see we have combined it into one retrorectus compartment. So within 10 seconds, I could make this concept very clear to you. Whether everyone would be able to do it, we don't know. So when someone is very capable to teach you these complex things in a simple manner, why should that knowledge go to only a selective few of residents? Say I'm based at Coimbatore, so why only surgeons in Coimbatore should have access to this knowledge? Whereas if you put it in a social media, people from all across the world can see this presentation and they would benefit out of it. So who's deciding on this monetization, and why should there be a monetization on surgical education? Again, now with a lot of laparoscopic and robotic surgeries, you can appreciate planes very well. So you can see the transversalis fascia is a very thin 1 millimeter structure, but you can see it very clearly, and we are showing you how to go in a true preperitoneal plane when you do a simple procedure like a TAPP. What about rare findings? Whenever we say rare findings, probably these are findings where surgeons only once in their lifetime would come across a scenario like this. So what about the surgeons who are not exposed to that? Why would you say that you should not be aware of how to deal with it? You can read about it in the book, but that doesn't give you a comprehensive management on how to go about these procedures. So here you can see this was a young patient with perforation peritonitis. On diagnosis, we found a Meckel's diverticulum, which is perforated at the base, which is not reported quite widely in the literature. Tip perforation is common, but not the base. So how would you manage it? You put a video on YouTube and everyone knows how they can manage it, or at least one way of managing it effectively. So then what about complications? Why should we wait for complications to occur to learn how to manage them? So here, post a low anterior resection, we are using an end-to-end stapler to do a anastomosis. We have fired the stapler, but you can see the anvil is completely detached. Now there is some blood clot. We are just sucking out that blood. Once we suck out the blood, to our surprise, we can see the entire rectum is open. So basically, the stapler didn't fire, but it just cut the rectum. So what is the problem and how to manage it? Nobody knows. We are not taught in societies or guidelines. So here, based on our experience, we thought we will just take a stay suture and use a linear stapler because we had some margin of the rectal cuff which was available for us to do so. So once you put this YouTube video, then a lot of people can learn, and you will also inculcate some ideas if at all you come across that complication, how to manage it. The major advantage with all these social media learning is that it is not necessarily happening only in the hospital. You can either do it when you have a free time in the hospital, or you can also do it at the leisure and comfort of your own home. So wherever you want, you can learn. If you want to learn, no one can stop you. That's the major advantage of social media. So I'm a young person. I've started putting these videos. A lot of them find it useful. And say I'm based at Coimbatore and I'm part of a medical college. Probably say I have 36 residents in a year who are coming for training. So that restricts my spread of knowledge only to those 36 residents every year. And even if you multiply it over 10 years, it's only 360 people who get benefited with my knowledge and teaching. Whereas you put it in a social media, almost 24,000 people are viewing these videos on a regular basis. And there are probably lakhs more people who haven't subscribed but still are viewing the videos. So that is the power of social media when you use it the right way. And this is in agreement with all the major societies as well. It's not only individuals, even SAGES, American College of Surgeons, WebSurge, which has been a good Bible and guide for a lot of young surgeons to go and see standardized procedures and know what are the right ways of performing these procedures. And that is not all. You can see a lot of future innovations which are coming into the social media as well. So here I've taken a video from YouTube. It's 3 years old, not new. So here you have a small marker. If you press that marker, you can visualize the entire OR setup. You can see where the assistant surgeon is standing, where the scrub nurse is standing, where is the table placed. You can see how the port positions are and what are the steps of the procedure. So this is like, virtual learning. You don't have to go there. So this surgery is done in Singapore, but sitting in Kerala, you can see how the inside of the operation theater looks like in this scenario. So rather than going and being as an observer over there, if you have a video like this, you are already in the center of the operation theater and you can have a broad overview of what is happening all across and all around you. And what about teleproctoring? So this is again a future and it is already coming in a big way. So I'm sitting at Coimbatore and someone is operating in Kerala and I can draw these annotations on the computer and that will be reflected on the surgical monitor. So the red is a bad zone, you can't go there, that is dangerous, you will have some injury. I can even give a commentary. And I mark you the right plane in yellow dots so that that is a safe zone and that is why you have to be dissecting. So say you have come to a proctorship, you've learned for some time and you're going and doing it on an individual basis, but in a smaller place where you don't have a surgeon backup as a mentor in the theater, then you can use technology to your advantage and try to bridge the gap and still have it performed in a very safe manner. So then what about surgical preparation? So before any surgery, now you can use these technologies and VR headsets. You can take a CT scan of a person, you can put it into the software and you can project it in a virtual environment. And you can have your surgical tools as well, like a scalpel or a scissors or a dissector. And using that, you can zoom in, you can change the axis and you can understand the vascular anatomy. So say you're doing a big complex Whipple surgery, you want to understand the nuances of your vascular anatomy, you can use these devices in a very meticulous manner to understand the patient's anatomy. So before the day of surgery, you can use this VR model to practice your surgery, and when you go in surgery, you know where to expect the vessels. and the same CT image also can be superimposed into the picture, and you can see at what level the tumors are. So this is the power, and when you use it in a right manner, in a judicious way, then I think social media is a great tool, and slowly it will start to replace and bridge the gaps which we have in surgical training right now. Thank you very much for your patient listening.
We have Dr. Madhu Murali.
Respected chairpersons, I think the debate is settled, I think, because no, jokes apart, I think Dipin forgot to convey the topic to Ashwin, I think. Because the topic was on mentorship, was not on YouTube as a learning tool or a teaching tool. The topic was YouTube as a mentor. And I never heard Ashwin using the word mentor during his 10 minutes presentation. So my catchword for this debate is mentor. What is a mentor? If the debate was about replacement of YouTube as a learning tool, then I should have a ground. If it was a teacher, probably I shouldn't have a role. But the topic is YouTube replacing role of a mentor. So what is a mentor? In the learning teaching process, we have trainee, trainer, guide, teacher, coach, etc., etc. Probably YouTube may fit in somewhere over there. But if you are to replace this with mentor, I don't think YouTube will be anywhere near any of those roles, because a mentor is a different concept altogether. It has been there in our mythological characters. Like here, Arjun was not learning just archery from Drona. He was staying with Dronacharya, learning life from Dronacharya. That is mentorship. But the other one, archery, is learning teaching. So today's generation should understand there's a huge difference between being a teacher or a coach and being a mentor. Now look at this. I hope you all remember this guy, Sachin Tendulkar. Look at the way the bat is held, look at the elbow position, and look at the foot position and the back lift, etc. And he had lots of coaches and trainees during his period. But if you ask him who his mentor is, he would say Ramakant Achrekar. So that is the difference between a coach or a mentor. Similarly, if you look at these three guys, they have won almost 90% of the ATP tournaments played over the last 10 years. Still, I don't think they used YouTube as a learning tool to improve their techniques or improve their, your hitting abilities. They had coaches, hired coaches. That's exactly why Atul Gawande said recently that you need mentors and coaches even after you pass out of an MBBS examination. Because surgery is not the technique of surgery alone. There's so many things that goes into the head of a surgeon, like your positioning, the way you stand near the patient, the way you place your cautery, the way the mistakes creep into your practice as you grow older and older. So you need repeated corrective measures throughout your career. And here, Atul Gawande was surprised that in professions like tennis, cricket, etc., you have coaches throughout your life. But in a highly skilled profession like a doctor or a surgeon, you stop to have coaches or mentors after you pass out your MBBS or MS courses. So you need to have mentors throughout your life. And that's why I said most surgery is done in your head. Your performance not determined by where you stand or where your elbow goes, determined where you decide to stand or where you decide to put your elbow. So you need to have a coach or a mentor constantly monitoring, not only for surgery, because the mentor's role goes beyond surgery. I'll skip all this because I think because the mentorship is different concept. So recently, 2024 February article of NEJM, a new graduate, neurology resident had written about having the need of a mentor in life rather than a teacher in life. Because mentor is somebody who has got genuine empathy and have no ego boundaries. The mentor may receive immense satisfaction from nurturing the mentee's development. Indeed, being a mentor is the most gratifying part of my work at this late point in my career, but this satisfaction is more than the benefit that the mentee receives. Now, what does the literature say about the role of YouTube as a teaching tool? This is a recent review which looked into the role of YouTube as an educational tool, and look at the green highlighted part. The educational quality of surgical YouTube videos is inadequate, insufficient, and heterogeneous. So even if we are to use YouTube as a learning tool, there should somebody to teach us or tell us or guide us on which would be the ideal platform to learn or to look into. And this was an article published in 2023. And there are more evidence coming up. This article looked into common 3 procedures, 73 videos, 202 videos, 100 videos of common surgical procedures, and what was the conclusion? 50% of the videos had misleading content, and the quality of the videos did not correlate with the views or likes. Sleeve gastrectomy, videos did not adhere to Lab Vegas guide. Now there are guidelines for video preparations, but still, even in 2023, about large number of videos are not adhering to the quality that these guidelines recommend to be there on the YouTube. Again, lap inguinal hernia, only 23% of videos were of good quality. So who would tell our residents, who would guide? Probably Ashwin Thangavulu's videos may be the highest quality, but every other video that is available on YouTube is not of the highest quality because only 20-25%. Who will guide the students? Who will let know the students that? Because likes and the views are not related to the quality. Now, so the conclusion of the meta-analysis was videos are useful as supplements, and available YouTube videos are unsatisfactory in education quality, and there should be a peer review process. And junior trainees were not able to look and appraise for themselves on which would be better tool. So again, this is another article published from our own country, All India Institute of Medical Sciences. Again, they also conclude that most of the videos of general surgery are of low quality, and again, the resident should therefore be cautious while making inferences based on YouTube videos. Again, the correlation between the views and the likes were seen only 7%. The remaining were not correlating. So the pitfalls of YouTube, if I were to conclude, is that surgery, mentorship, as I said earlier, is different. Even if you use YouTube as a learning tool, surgical views that you get in a YouTube is single view. And again, the surgery is not about the cutting or that happens at the tip of the cautery. It's about hand holding, dynamic movements, manipulations, suturing, etc. And you need so much of cognitive skills added on to a surgical skill to be a good surgeon, like situation awareness, task management, handling complication, and decision making. So YouTube may be a good learning tool, but will it replace a mentorship? I don't know. And if it is knowledge or information that you're looking at, internet or YouTube may be an option. But if you are wisdom, you're looking at wisdom, a mentorship should be there, because YouTube videos provide short-term knowledge and augment the coping ability, not retaining ability. So again, I belong to Generation X, but the people sitting in the back are the millennial generation. Do they need mentoring? There was again a JAMA article published in 2018 telling that even the junior colleagues or even the millennium students need mentoring, and their mentoring should be of a different type, micro-mentoring. So mentoring should be there throughout the life of a surgeon or a person, because learning surgery is not about learning the techniques of surgery. It's more than that. It's about how to be a good person. Now, just before I conclude, as it is about mentoring, I put some pictures over there. This is a picture that our chairman put up 2 weeks back. And he is the head of the department of a department. He's the chairman of the ASI and the superintendent of one of the largest medical colleges in this state. And I masked a part of it. If I reveal it, you will know what a mentor is. This is the one he put up on the Vishu Day, saying that he's a mentor. And I think Srijan sir is still under the mentorship of Rajan sir, who is sitting there luckily as the chairperson of this debate. And who else should I project over here? My own mentor, Babu sir. So Babu sir had taught me surgery only for 3 years, from 2001 to 2004. But if I have become a good person in life, or if I become somebody worthy of standing here and debating on this topic, it is because of the 20 years of continuation of mentorship that he has given to me all after 2004. Because this guy, who was a junior resident at Kottayam Medical College, has evolved into a person, and if I'm able to hold my heads high, it is because of the mentorship that I got from this person. Not only this person, other people who have had significant influences on making me what, at least for my sake, I don't need to tell the name, Santosh John sir, Rajan sir, Srijan sir, and again you just heard Jairaj sir talking about the Yagma sir. And again, from my Kottayam experience, there are 3 or 4 people, Benny sir, Sunil sir, Pradeep Jacob. And I don't think on any day I would exchange this for a YouTube channel or something, because it's mentorship. And lastly, a few other people who had a significant role. So dear friends, YouTube is a good learning tool, and you should utilize that. But if the debate is about mentorship, surgical learning goes beyond that. But there are pitfalls in YouTube, because all of you would remember this particular video from Boeing, I don't want to have the video displayed here because if you try to learn from YouTube, you would end up making chicken curry the way Mohanlal made chicken curry in Boing Boing, and hope you remember this video. If you don't have an access to, please go to the video and understand that, because YouTube videos as it is today have their own problems and it has to undergo more refinement, but whatever refinement they undergo, I don't think they will ever reach the role to the level where they can play the role of a mentor. And remember, the debate is about mentorship and not about YouTube as a learning tool or a learning device. Thank you so much.
Thank you, Madhu Murali sir. We have the rebuttal from Dr. Aswin now. 2 minutes.
It's a wonderful talk. So you put up pictures of some senior surgeons. So from this crowd, how many of you had the privilege to work under them and had the opportunity to get the mentorship? Could you just show with the raise of hands? So that's 20%, me being very liberal. So what about the rest of the 80%? What did they deserve to not be under the mentorship of those great doyen surgeons? So that is the problem. I don't have a problem with mentorship. Every person over here is undergoing your surgical residency or you have completed it. But surgical teaching and learning doesn't stop with that. So when probably sir looks very young, but maybe when he did his MS residency, laparoscopy would have not been very widely used. Whereas now I'm sure sir would be doing laparoscopic surgery. So if you have said I will stick to traditional teaching and learning, then you won't evolve. But now you are evolving. So I'm sure even you need medium to refer to and keep improving on your techniques and find various ways on how to improve your skills. So my problem is that you have wonderful mentorship. So you have an association with 1,000 people, whereas you didn't even put 1% of that. You showed less than 10 people as your mentors. Why is that? So what about the rest 990 people? So if they're not at the same level, why are you preventing the exchange of education? That is my problem. And with the evolving of technology, I thought I was also a mentor. I might not be a conventional mentor in your mind, but you won't believe me that in a lot of Tier 3 and Tier 4 cities, where they have not had exposure to learn all these procedures and they don't have a good surgeon to teach them, a lot of these videos are helpful to them. So that is the motivation why we keep on putting the hard work and try to give them good quality videos. And the proof is in the pudding. You showed a lot of papers. In none of the paper, they said that YouTube should not be used as a teaching tool. They said it's a work in progress and you have to probably scrutinize the process and have it more peer reviewed so that the knowledge which is being spread out is done in a proper manner. So that is why arguments would be ending. Thank you very much.
Madhu Murali sir.
No, I don't have much to add. Basically, let me tell you, for the sake of junior sitting over there, every other successful person sitting in this crowd would agree that they have had a mentor. If you have not had a mentor till now, please find out one and undergo mentorship under him, because a mentor makes a difference. A mentor makes a difference. And every other successful person who spoke over here, and what did Jayagumar, one of the most successful person we relate to is Jayagumar. What did Jayagumar say? He was saying that Babu sir taught him in 1984 how to make a presentation, something. So mentorship, I'm not saying that YouTube or any of the social media are not good learning tools. They are very good learning tools. I also use them to refine my techniques or look into areas which I don't know or I'm not doing properly. But YouTube or any sort of videos are excellent tools. But do have a mentor. It makes a huge difference. It's more than a teacher. It's more than a coach. It's more than a trainer. A mentor, you need a mentor. If you don't have it now, please find out one. That's all. Thank you.
Both the points are well taken. Excellent debate. We have a very long history, rich history of a teacher-student relationship. We have the Gurukul long back before the internship concept even came up. And very good points from both of you. And as sir brought out Dronacharya and Arjun, just to, on the younger side, I would like to point out, there was Ekalavya, who could not get Dronacharya as a teacher to him, but he was able to keep Dronacharya as a mentor, and then he could bring out his talents. So that is one way I would look at it, being a younger person, agreeing with Dr. Aswin. Rather than the question being like it is replacing a mentor, whether it would be an extension of a mentorship. That's what I would like to put it. It will never replace a mentor, but definitely is a good tool where you can extend your mentorship to a wider audience. So that is my take on this whole thing.
Thank you, Dr. Aswin and Dr. Murali. Good Lord, this is not a court of law, and we are not judges. The points are well taken. I do agree that we all came through that particular concept of mentorship, and nothing has been lost because of that. True, and the world is changing, and now that you can reach the world over in seconds, no problem. You have got this as a learning tool, it's good. But as to make a good human being, as a good doctor and a good surgeon, I still feel that you can just think of someone who has taught you. And in very many ways, this has helped very many people at very many times. This is what I would like to comment. So both of you have done, you have put your points very well, quite right. When you talk, I would say that, fantastic. And when Madhu says, yes. So to judge which is which, I still, as an old man, say that a mentorship is a good quality, a good methodology to be still followed, and you can always think of someone. As Srijan always used to say that at midnight I can call him, and I do help him even at midnight. And that's a different thing. That's a different friendship or relationship that we continue. But as you rightly said, raise 10 hands. But each student to learning surgery would probably look upon somebody. That's my view, right? And you confirming your view is that you can still go on to thousands and thousands of people, and that's a good learning methodology as well. Thank you very much.
Thank you, sir. Excellent debate.